right, good evening, everyone. Welcome to Henry Schein Dental Academy webinar series, and probably the best pregame show for the NBA finals tonight. So it's a great way to start the evening. And Dr. Kohltfarber, your popularity precedes you. We've got a great number already in the first minute. So we're very excited to have Dr. Kohltfarber presenting tonight. I'll be your moderator. I'm Dr. Gary Severance with Henry Schein. Dr. Kohltfarber will provide some best practices for patient selection in the general practice. A couple things before we get started. At any point during the webinar, please use the chat to ask any questions, or specifically the Q&A to ask any questions, because we'll at the end be able to ask Dr. Kohltfarber live those questions and get those answered throughout. And as a reminder, Henry Schein is not offering CE credit for viewing this webinar or the recording. You will get an email with a recording session as well in case you have to leave early or got started later. So we'll remind you at the end as well. So with that, I'll turn it over to Dr. Heidi Kohltfarber. Dr. Kohltfarber.
Thank you so much, Gary. I appreciate the opportunity, and I appreciate all of you that are taking your time this evening to hang out with me a little bit and talk about 3D patient selection. And I know that's kind of a hot topic. There's been a lot of discussion over the years. There have been quite a lot of papers put out, various projects looking at what should be our selection criteria for 3D. So let's go ahead and talk about those. All right, so some objectives that we're going to understand the various uses for 3D imaging, understand what our responsibilities are as practitioners, and to be able to discuss selection criteria for 3D imaging. So those are the objectives tonight. When we're talking about 3D imaging, there's actually quite a lot of 3D imaging that is out there. We have things such as cone beam CT, which we have in our offices, of course. There's also medical CT, and there's also MRI. So there's a lot of things when we're talking about, patient selection for 3D imaging as far as various diagnostic tools. Now, I'm going to talk really quickly about MRI and medical CT and their uses, because that is something you should be familiar with, and just kind of have in the back of your mind that there are other diagnostic tools if you should need them beyond cone beam CT. So we're looking at MRI. Pros, great for assessing any type of tumors, something that's not well defined, evaluating any of the soft tissues of the temporomandibular joint. So remember, with our CBCTs, we're only looking at the hard tissues. We're not looking at the soft tissues. And if we want to look at those soft tissues, we're going to need to get an MRI for our patients. Nice thing about MRI, no ionizing radiation, but downsides, very long scan times. Motion artifacts become an issue. They're expensive. And I'm going to go ahead and put another one in here. Image resolution's not that great. So then, of course, we have our medical CT. The pro with that, it has an unlimited scan volume, so we can go beyond just the head. So if the patient's complaining of some other issues, you might want to go ahead and send them for something that's a little bit larger of a volume size. It can do multiple revolutions, and because of that, it can kind of make up a little bit for those motion artifacts. And it's very, very fast. So they use, of course, for cardiac imaging. It really is the standard of care for trauma. And actually it'll be interesting to see how that standard of care for medical CT kind of trickles down into our cone beam CTs over time. Because we know that if there's any type of head trauma, everyone's required to take a medical CT. You can also get soft tissue detail. So it'll have a bone window. So essentially you can see that this bone window right here looks very similar to our cone beam CTs. Our cone beam CTs are in essence a medical CT with a bone window, but they can also flip over and do a soft tissue window and look at all of the soft tissues as well. They also have hard tissue detail, as I said, but it is expensive. There's a lot of beam hardening artifacts, and it is a much higher dose to the patient. So we're looking at our CBCTs. What are the pluses to it? Obviously, excellent hard tissue detail. We don't see all the soft tissues that we saw with medical CT, but that's actually a huge plus for us If we had to go through and evaluate all of the soft tissues of the face, if we had to evaluate brain, this would take us a lot of time, and it really would not be helpful for us in dentistry, I would say. So it's kind of nice we just see the hard tissues, which is what we want to see in dentistry. So excellent hard tissue, very high resolution. In fact, much higher resolution than a medical CT. And we have nice isotropic voxels. So what it means is that we have a perfect cube. And so each one of our little 3D pixels is a perfect cube. So we can have reconstructions very nicely in all three planes. We're not waiting to try to reconstruct into different planes like you would have to with a medical CT. This does come at a lower dose and a lower cost to our patient, but the cons to that, again, I kind of alluded to a little bit, one revolution. So it goes once around the head. And so motion artifacts can be a big deal. It's important for us to be able to visualize and understand those motion artifacts and retake if we need to. Limited scan volume, it's really just for the head. Although we do see people sticking whatever they think they've broken into it, and I would totally do that too. But my caveat, legal caveat, it's just supposed to be for the head. Lots of scatter. It really is just hard tissue only, as we talked about. And we do have beam hardening artifacts, but on the average, I would say it's less than medical CT. I think that some of the imaging companies, especially with CBCT, have really figured out how to handle some of those beam hardening artifacts with various algorithms and filters. But what about our practitioner responsibilities? So the American Academy of Oral and Maxillofacial Radiology recommends that the practitioner should follow selection criteria guidelines, which we're going to talk about today, use dose optimization, be technically proficient in the use of CBCT. What does that mean? It means to understand your machine, know all of the various presets that you have, and be able to either read your own CBCTs or know how to send those out. But basically says be technically proficient in the use of CBCT. We need to understand radiation safety, which of course many of us do. We've learned this ever since we were in dental school, so this isn't new at all. And we need to perform 3D imaging for valid diagnostic or treatment needs. And we'll talk a little bit more about what that is. It also states that we need to be able to correlate the CBCT findings with 2D imaging. Why might that be important? Well, actually, we can learn quite a bit from that. In fact, if you go back to your 2D, you might say, oh, wow, that's why I was seeing what looked like a lesion. So I think this is a great learning opportunity for us as well. It actually will enhance your diagnostic skills in 2D as well. It does also say be held to the same standards as an oral and maxillofacial radiologist. Well, this is exactly like any specialty. So if you were to do a root canal treatment, you're held to the same standards as an endodontist. If you extract a tooth, you're held to the same standards as an oral surgeon. So I think it's with anything that you choose to do that's, many times considered definitely within the realm for general dentistry, but we're always held to those higher standards. And so it's the exact same thing here with reading and evaluating your scans, is that you'd be held to the same standards as an oral maxillofacial radiologist. Now you might think, how can I get out of that? Maybe that's a little bit too much for me right now. No problem. If you send that scan on to an oral maxillofacial radiologist to read, you have kind of relinquished that liability. You've handed it over to them. You're not responsible for that. What are our responsibilities as far as viewing the volume? Well, the entire volume must be viewed and interpreted. And then it says a report should be generated for each patient case. So this is letting us know that we need to evaluate the entire scan. Many times we're so eager just to look at the mouth that we key in on the area and the reason that we took the scan, and we forget to look at all of the other area. It is important to look at things globally first, evaluate the entire scan, and then come down to the reason you actually took it. And the reason for that is we do find a lot of other incidental findings in our patients. It's important for us as dentists because many times we're catching it before the medical professionals. it's important for us to be able to point that out to the patient and send them where they need to go. And again, you're not alone in this. If you have any questions, there's a host of oral maxillofacial radiologists that are happy to help you. What does it mean by a report should be generated? Well, basically it means you need to put something in the notes. So if you want to be going through the scan and maybe have your assistant sitting next to you, and you might want to say, there's tonsillis within the palatine tonsils, or, there's ossification of the stylohyoid ligament, or, that kind of a thing. It just needs to be documented as you go through. And so many times an easy way to put that into your workflow is to sit down with your patient at that diagnostic appointment. You have your assistant sitting next to you, and as you review the case, which patients love to see themselves on CBCT anyway, as you're reviewing the case with the patient, you're just mentioning all these things, and your assistant is typing it all into that patient record. And therefore, you have a report. It says the AMR encourages the use of CBC technology within the practice of dentistry where this results in healthcare benefits for the patient. So there has to be some type of a benefit for the patient. We have to be able to establish there was a benefit. Basically, we need to say why we took the scan. And that will come up again later with our documentation. Why was the volume recommended? And that's very easy to say. You might say, patient has prolonged pain and 2D imaging is not showing what's going on with this patient. Or, patient may be at high risk for something. Or, patients complaining of issues with the temporomandibular joint, and we really can't evaluate that in 2D imaging. So just really simple, why was the volume recommended? Usually that's not hard to come up with. A separate consent form may be needed, and this is a recommendation, but when these things go into a court of law, many times the consent form is what they go after, and they'll say the patient wasn't fully informed, even though they might have signed 2 or 3 of them. Still smart to go ahead and have some sort of a consent form that's written up for your patient. You might want to talk about, radiation dose, why they might need this, why this is important. You probably already have something like that in your office. And then we use a systematic approach for evaluating each case. And I know I've talked about this before, but we're going to kind of quickly reiterate it. We want to talk about patient information, give a brief history, symptoms, talk about any clinical examinations, review existing dental radiographs. So you're looking back, is whatever you're concerned about, is it getting larger? Is it staying the same size? Or monitor. Maybe we want to monitor something. Maybe we want to reevaluate in 3 to 6 months and see if there's a growth potential that would require a biopsy. So kind of some documentation. Most of us that went to school, especially in California, it is such a litigious society. Its documentation was just ground into our heads. And so this is probably not anything that is new for you. Same guiding principles as 2D. Justification, optimization, dose limitation. And we'll talk about this a little bit. So when we went to school, we learned about dose justification, patient selection. Not every patient needs the exact same type of scan or the exact same type of images. ALARA, as low as reasonably achievable. So we want to provide dose that is diagnostic, but be able to stay as low as possible. And with that, we found with some of these units, especially when we had the image intensifier units, it was actually possible to be too low. And so they've looked at maybe changing this to as low as diagnostically acceptable, because it's important that we have a diagnostic image in order to correctly evaluate that patient case. So here's an example of a poor image quality, an underexposed image. And this one was sent in because they wanted to look at the periodontal ligament space. We want to look at the periodontal ligament space too. You can see how noisy this image is. This is an underexposed image. So what's happened here is they have a large adult and they didn't take the scan at the large adult setting. Many times for large adults, we need to make sure it's at the large adult setting for a reason, because there's so much noise going on if it's not taken at the appropriate exposure setting. So what happens with something like this is this patient case gets sent back. We'll say, go ahead and take it at the appropriate exposure setting and send it back in. And what does that do? Well, overall, that results in an increased dose to that patient versus if you had just taken it at the appropriate exposure setting to begin with. So we don't want to be afraid to take things at the proper exposure setting for that patient, but we always do want to be careful. So dose optimization, that's having patient-specific scans, using the appropriate exposure setting for the size of the patient. And again, sometimes we get so afraid to use that large adult setting. Don't be afraid to use that large adult setting if you need that, because overall, these machines are really very low dose units. Limit the field of view to the region of interest. Certainly, and definitely, if you're thinking about something with endo, if you limit it to the size of the field of view that you're interested in, it'll actually give you a higher resolution. So I think if you go down to like the 5x5 centimeter fields of view with some of these units, it's going to give you a much better image resolution, and you're going to be able to see things a little bit better for endo. Use personal protective devices when able to do so. So when you can use a lead apron, when you can use the thyroid collar, but remember that these can also get into the field of view. And I think I've got a nice picture of that later on we'll talk about. So one of the things we do want to be careful about, we always want to be careful with children. The reason being is that they have a higher rate of cellular growth, their organs are developing, and they are much more sensitive to ionizing radiation than an adult will be. Also, because of the latency period for cancer. So how long would it take for a cancer to occur from ionizing radiation? If we're talking about something like a squamous cell carcinoma, this is going to cause, or even like thyroid cancer, that's going to take about 30 years to occur, which is funny because usually the people that are so incredibly concerned are like your 60-year-old females that have watched Dr. Oz. Pretty sure that's not going to be what gets her, but in any case, we want to be sensitive to the needs of the patient, but just so you know that. Latency period for something like a lymphoma might be as soon as 15 years. So when we're looking at the lifespan of an individual, certainly a child's going to be much more at risk than, say, an adult. The currently held models show a linear non-threshold model for ionizing radiation as it pertains to cancer. And so what does this tell us? Well, we feel that there's a cumulative effect of that damage of ionizing radiation throughout the lifetime of an individual. It just means at some point something may or may not cause a cancer to occur. The other thing that we need to think about is children are much smaller than adults. So when they're sitting in that machine, there's a lot more of their anatomy that's going to be imaged. And because of that, they actually have much higher doses than an adult would have, just because increased amount of anatomy that's actually being ionized. So we're always really careful with children. There is something called the Image Gently campaign. And if you have not heard about it, this is something you should look up. It is mandatory for physicians to have taken the pledge for the Image Gently campaign. That is coming into dentistry. You may as well be ahead of the curve. Go ahead and check out that website for the Image Gently campaign. You can take their pledge, and then you can use their logo on your website. And it allows your patients to see that you're very cognizant of dose, you're very careful with the pediatric population. Basically, what it says is one size does not fit all. So you sign something that says that you're going to be selective for the individual's needs, not merely taking it routinely on every child that comes through. Use the fastest imaging receptors possible, which most of us are going to have digital sensors anyway, which is the fastest. We'll collimate to the area of interest, use a thyroid collar when we can, especially, and use that pediatric dose setting. So that's very important. Now, we don't want to be afraid to use a CBCT if it's necessary. And definitely there are times when it's necessary, even with a child. So don't be afraid of that. This is a fantastic tool in your toolbox, but we want to use it responsibly, just like anything else. So basically this says when we image, let us image gently, and more is often not better. And this is really geared toward the medical community. When you think about some of the medical CTs, those are much more dose than our CBCTs. And so they were trying to limit the dose for the children as far as taking ionizing radiation like medical CTs. But like I said, it is coming into dentistry and you may as well be ahead of the curve. So check that one out. This is the thyroid collar. So funny thing about this, because they always say, well, you should use a thyroid collar. And certainly there are times to use this, definitely. And if you can use it, that's great. But don't get it in the field of view. If you get it in the field of view, you can see all of this beam hardening artifact that basically makes it indistinguishable for you to see things on the inferior aspect of that scan. Basically, anything in the mandible is not going to be diagnostic. So if you're going to use it, you need to make sure that you're able to do so without it getting into the field of view, because if it's in the field of view, it completely ruins the diagnostic quality of that scan. What would happen is you would need to re-image the patient. And again, that's more dose to the patient than if you had just done it the first time without the thyroid collar. So something to be careful and to think about when we put a thyroid collar on. There are some other recommendations. This is from Dr. Ludlow et al. And his image gently recommendations say CBCT dose can be significantly reduced by increasing that voxel size. So when we increase the voxel size, we have decreased that image resolution. So instead of taking it at maybe a 0.1 millimeter scan, we have taken it at 0.4. We won't see fine details as well, but many times, especially when we're taking these images for children, that's perfectly fine, because most of the time we're taking it for things like orthodontic treatment and that sort of things, more looking at things on a macro scale than a micro scale. Reduce the field of view. Don't use the high resolution settings, such as the high definition or HD mode. Use the appropriate child exposure setting and follow guidelines for CBCT use, such as in orthodontics. And we'll talk about that as well. Now, there is something called the Image Wisely campaign. This is a similar thing to the Image Gently, but it is for adults. And basically saying the exact same thing, that we're going to be very careful with imaging. We're going to take it when needed. We're going to treat each of our patients as an individual. We're going to use any type of, lead apron or thyroid collar, anything like that as needed as we can. So, all right, what does this all boil down to? If you're looking at that going, wow, when should I take a scan? Just know it all boils down to your judgment. We're not sitting in your dental office. We don't know. If you feel you need it, it's completely up to your judgment. We know that there are professional pressures, there's patient pressures, there's economic pressures, the medical legal pressures. What does it all boil down to? Will this CBCT affect the management of your patient's case? Is it going to affect the dental treatment that you're going to provide? And if it is going to be positive, if it is going to help you be able to better visualize, then that benefit outweighs the risk. So we're always looking at that risk-benefit analysis. There are various position papers. There's ones for implants, endo, ortho, and then there's the Endodontic project. This was sent out by the European Commission on Radiation Protection, and you can find that. There's actually a paper, and it's number 172, so you can review that as well. So let's look at some of this, because it might be hard. You might say, wow, maybe I'm not sure exactly what I should be doing now. So these are some of the recommendations, and these are some examples of when to use it. This was one of the implant position papers. This was sent out by the American Academy of Oral and Maxillofacial Radiology in conjunction with dental implantology. And it recommends that cross-sectional imaging be used for the assessment of all dental implant sites, and that CBCT is the imaging method of choice for gaining this information. It didn't say it's standard of care, but it did say that it strongly recommends it. And we do know that a couple of years ago, the malpractice insurances started coming to our academy meetings and telling us that if something goes wrong after an implant is placed and the dentist does not have a CBCT to show proper planning, that they are not defendable. Basically, they'll just pay it out. So they haven't come out with the word standard of care exactly, but it's kind of sounding like standard of care. So something to kind of think about if you are placing implants without a CBCT. I know myself personally, after seeing what I see day in and day out, of course, we see the good, the bad, and the ugly. So we probably have a biased population, but I probably wouldn't be placing implants without a CBCT. It's just such a fabulous tool, and we have it at our disposal, and we definitely should use it. But we know there's different anatomical features that make it difficult for us to see things on TD, such as the submandibular salivary gland fossa. We always want to be careful of that if we're placing an implant. We know that we have our lingual artery coming through there. We don't want to extend through and cause some type of dehiscence. We don't want to penetrate that. It's just best to avoid problems. If you see things in all three planes, you're able to better diagnose and plan for your patient's case. And of course, we know the CBCT can be very, very beneficial for us. It'll let us know if we have a favorable versus an unfavorable ridge. We can play around with it. Of course, all of the software comes with options. And so we can actually pick which implant we're going to place. We can mess around with the size, with the orientation. We can see if it's going to fit ahead of time. Look at our length and diameter, axis of orientation, and the ideal anatomical location. So, from that kind of a standpoint, there's really no reason for us to have any issues with placing an implant. I would say also one of the best reasons for CBCT systems is the surgical guides. And especially if you're just starting out and you're kind of nervous about this whole process, a surgical guide is such a godsend. It's going to tell you exactly how to do everything. It's going to come with a nice little recipe to follow. We actually tested this out with some of our students. We did a couple of different kind of pilot studies with various imaging companies. And we found that even with, say, our third year dental students that are just starting to place, our class 2 and 3 restorations, they're just getting up on clinic, they were able to place implants appropriately and repeatedly in the correct position. And then the variation in their repeatability, I think, was like 0.4 for one of the pilot studies and 0.3 for the other. That's pretty nice accuracy and repeatability there. So I would say that, if our third year dental students can do it, you can definitely do it. And the surgical guides are definitely worth the money, especially in the beginning. It'll really help you to be able to understand things a little bit better. So I would highly, highly recommend that. So here's a case where a surgical guide was used. This was done in front of a live audience of about 200 people. Pretty sure that the oral surgeon that placed this was a little bit nervous. You can see we have very, very limited space, and he was able to place that implant perfectly with a surgical guide. And you might say, ooh, that was kind of close on both sides. I wonder how that's held up. And I probably need to get a follow-up to this. That would be really cool to get a follow-up for it. So, but anyway, fabulous case, definitely a good reason to use our surgical guide. Because we know that even if you have a huge space, and even if you can plan things correctly, we can't always place it correctly. Things go wrong once we move into the mouth. And so having a surgical guide is very, very helpful. Here's a couple of different examples of cases that maybe didn't have a surgical guide. Here we have an all-on-4, except for, oops, that one didn't quite seat. This guy, definitely we didn't have proper planning ahead of time because we can see that implant's hanging out in the sinus. And just because it's kind of hanging out in the sinus isn't necessarily bad. We don't see a mucosal thickening. We don't have surrounding inflammation. But how much bone is actually holding that implant in place? And so the longevity of that implant is going to be an issue. This is a case post-grafting. So this is the 2D image, and they've placed their graft. They think it looks pretty good. It's probably, osseo-integrated into the surrounding bone. And when they took the CBCT ahead of time, thank goodness they did, what happened? Well, where'd the bone go? Actually, we have a large fibrous defect We have an extensive mucosal thickening on that side that is iatrogenic in origin. Where did all of our beautiful bone graft go? Well, the patient swallowed it. So that was a pretty expensive swallow. This was another case. This is our post-grafting. And we can see if I can put that up. There we go. Hopefully we can see this a little bit better. So we can see all of our graft material. They went ahead and took the CBCT. And where is that graft? It has pretty much escaped the membrane. It's everywhere. It's all in the buccal soft tissues. It's pretty much everywhere except for where we really wanted it to go. So definitely important to look at our post-graft with a CBCT before placing an implant. It's gonna let me. And I think my little computer is telling me that it's the end of the day. There we go. All right. Post-site preservation bone graft. So here was another one. What happened to our site preservation bone graft? Well, same thing. It's up here floating within the sinus. We actually have mucosal thickening in the sinus. We have thickening and sclerosis of the cortical border. We now have a chronic inflammatory process as a result of attempting to place our post-site preservation bone graft. Definitely, again, something you'd want to know ahead of time. So I can't reiterate that enough. These are very good reasons for taking a CBCT ahead of time. And of course, we can see that we have extension now of that sinus into the lateral aspect of the nasal fossa. This is starting to look like a mucocele. Obviously, that's a little bit rough. We're going to have to refer this to ENT, have them clean it out for us ahead of time, and then try to place our bone graft material again. All right. This was a sinus augmentation with implant placed. This is our 2D image. It looks pretty good. Looks like we placed our implant exactly where we wanted it to go. And yet when we're looking at our coronal sections, you can see that the augmentation is actually buccal to the implant, and the implant has been placed lingual. We actually have very minimal bone holding that implant in place. So, and of course, we have a mucosal thickening, letting us know that we have an inflammatory process. This was one implant was placed without a CBCT volume. And these are angled posterior maxillary PAs. And at this point, I think I should probably give my caveat. A lot of these clinicians are excellent clinicians. Everybody can have a bad day. We definitely know that. We see the good, the bad, and the ugly, as I said in radiology. We have a very wide no judgment zone because many of us have been there. We know exactly that these things can happen. Unfortunately, this individual did go ahead and measure the amount of bone that they thought was there from the angled posterior maxillary PAs. Came running down to radiology, and the complaint was, I lost the implant. And guess what? We found the implant. In fact, the implant looks just as shocked as we do. So obviously, this is a really bad day for the patient. This is a really bad day for the clinician as well. This is very, very stressful. This is not somewhere that you want to find yourself. So if you take the CBCT ahead of time, it could help to prevent this type of thing by allowing us to treatment plan more accurately. And so definitely a CBCT is a good idea if you're going to be placing implants. This one, the 2D, looks like that implant has been placed correctly. Looks like this is restorable. Actually, probably looking at this thinking, wow, we did a good job. But in the 3D, where's the implant really? It's sitting along that lingual cortical border. And we're looking at our coronal sections. This is the only amount of bone that's holding that implant in place. And this is not going to be restorable for us. So again, planning, planning, planning. This patient came in. The chief complaint was that they had had a history of a failed implant. So they were new to this particular office, took the CBCT, and guess what? We found it. So it is anteromedial to the sinus. It is actually osseointegrated with the lateral cortical border of the nasal fossa. We know the majority will osseointegrate. They integrate wherever they are at. And so this is kind of going to live out its life there. So, you know, I'm sure these guys took the nasal fossa implant course. What about this case? Implant near the mandibular canal. Well, we definitely want to trace that mandibular canal before placing implants. Here, especially in California, we will see a lot of cases that are brought into court because the implant has perforated the canal. And definitely want to be very, very careful of something like that. We know there's a lot of canal variations. And so definitely want to trace that ahead of time. We can have mandibular canal bifurcations, anterior loops. Check out where this implant is in relationship to that mandibular canal. So that's probably not a very good day right there. We can have superior accessory canals taking off. So here we have a superior accessory canal and then another canal that goes down and rejoins the mandibular canal proper. If you see a superior accessory canal on one side, you might have one on the other. And of course, the mental foramen. We can have variations. We can have one foramen, we could have two foramen, we can have three foramen. So the anatomy has not always read our textbooks, and it can pretty much do what it wants to do. It's up to us to be able to better visualize that. This is an interesting case with a subperiosteal implant. And we ended up with a mandibular fracture. So the patient came in complaining of pain. There was drainage and inflammation. And with the CBCT, we can see that fracture. All right, what are the recommendations for endodontics? They recommend limited CBCT. You want a high resolution to be able to assess the canals, root fractures, and that sort of thing. They say it's time savings if you have a smaller volume to interpret. You're just looking at a couple of teeth. Although surprisingly, we find that many of these smaller volumes take us just as long a time to look at as the larger volume, because now we're looking at tiny minutia. But really, we want to be able to decrease the dose where possible. So, limit that field of view. They say CBCT should not be routinely used for screening purposes in the absence of signs and symptoms. Now, if your patient comes in and has signs and symptoms, it is okay to go ahead and take a CBCT, especially if the 2D imaging doesn't show you what you want to see. Again, the benefit to the patient must outweigh the risk. So kind of the similar terminology, we're going to hear it all the way through. CBCT should only be used when lower dose radiographs fail to demonstrate the problem. So they say, go ahead and take a 2D first. If you can't see it, move on to the 3D. Some other recommendations of when you could take it. So these are, when you want to do it. Potential accessory canal, if you're concerned about an accessory canal. If you're concerned about any type of anomaly or root curvature, if you need to be able to better diagnose your periapical pathologies, or if there's poorly localized, non-specific clinical signs and symptoms in untreated or maybe a previously treated tooth. Complications such as overextension of your obturation material, separation of any type of endodontic instruments, a calcified canal, any type of trauma. Definitely, this would be a time to go ahead and take a CBCT. External versus internal root resorption, pre-surgical planning for apicoectomies or dental implant planning. So basically what it tells you is there's some pretty wide berth in here. If you feel that you need it, again, it comes back to the judgment of you sitting in your office. If you feel like you need it, don't hesitate. And definitely you can justify. These are all reasons to justify taking a CBCT. So let's look at some examples. They weren't entirely sure what was going on with this little tooth here. This is our 2D. And in 3D, you can see the dens and dentate much better. So it's a little tooth within a tooth. Obviously, we'd want to look at the apical region because we know that many times with the dens and dentate, there's a communication with pulpal tissues. Many times these have periapical lesions. We tend to see these more on our maxillary laterals. And if you see it on one side, check the other side. Higher possibility that we'd have it on the other side as well. Periapical lesions, if we can't see them in 2D. And when might we not see them in 2D? Well, the original studies that were done by Bender and Seltzer in the late 1960s said unless the buccal and lingual cortical borders were breached, we won't see the periapical lesion. But now with CBCT, we are seeing between those cortical borders. And so we can catch these things very, very early on. And so we can definitely see we've got some nice periapical lesions going on. Here we have a mucosal thickening, and this is odontogenic in origin. So whenever we see a localized mucosal thickening in the sinus, we want to go ahead and check the apical region and rule out an odontogenic source. So certainly, if we're concerned about a periapical lesion, we may not be able to see things well with 2D. That is a reason to go ahead and move into 3D. Of course, combined endoperio lesions. So the more complex it becomes, the smarter it is to take a CBCT. And so definitely here we have chronic inflammatory process going on. We've got drainage. So here's a sinus tract. Here we have some bone loss extending into the furcation region. You can see extensive amount of bone loss here. So most likely we're looking at something that's combined endoperio. Here's another combined endoperio lesion as well. So any of these you want to go ahead and look at. We want to rule out a root fracture. Be able to evaluate that just a little bit better with the CBCT. What about this? Well, that tooth, look at the location to the mandibular canal. So definitely if we're going to be doing an extraction or we're going to be doing an apicoectomy or anything like that, you want to know where your mandibular canal is. What if they have multiple periapical lesions? Well, go ahead and take a CBCT so you can better evaluate all of them. Here, of course, we have an asymmetric widening of the periodontal ligament space on a tooth that's been root canal treated already. Obviously, we're going to start to think about a root fracture. And that brings us, of course, to our non-healing root canal treated teeth. When I went through dental school, they let me know that this is a failed root canal, but then when I went back to school for my residency, the terminology had changed. It had become more PC. This is now called a non-healing or an unresponsive root canal treated tooth because I didn't fail at doing anything. The tooth just failed to respond. So, you know, in our PC culture, or somebody told me if you did it, it failed. If I did it, it's non-healing. So yeah, kind of makes us feel a little bit better. But anyway, things that we might want to look for. And I think this is one of the things that is the most frustrating. And this is actually what brought me into 3D imaging. You know, you've already done the root canal treatment. The patient has a new crown. Everything looks like it's going great. The 2D images look great. The patient has continued symptoms. And I can't figure out why based on that 2D imaging. So that's really what pushed me into 3D imaging. But again, being able to see between the cortical borders, now we can see, yeah, there is a continued periapical lesion. Here we've lost the inferior cortical border of the sinus. We have a mucosal thickening that is odontogenic in origin. And the things that we're going to look for here are going to be an unfilled canal, a perforation, or a radiolucent fracture line. And now we may not always see the fracture line with CBCT. We do have beam hardening artifacts that might make it difficult for us to see it, but we're going to look for the evidence of a fracture. And so we'll see some examples of that as well. So here we have some missed canals. We can definitely see missed canals quite easily with our CBCTs. Of course, we have a nice little periapical lesion right there. Another one, we've got a couple of missed canals on this one. Somehow we completely missed all of these canals. This one again, another missed canal. So, you know, it's easy to see our missed canals with our CBCT. I would say that more and more, especially with the finer resolution or the higher resolution machines that have come out, we can see those pretty well. What about extruded endomaterial? Yeah, we can definitely see that. We can try to rule that out. We're trying to determine, is this maybe a file that has separated or anything like that. In fact, some of the times we can actually see the corrugation on that file. And so we'll know, yeah, we definitely have a file. Here's a great case of a root fracture right there. You can definitely see that. The fracture line has to be displaced more than the resolution of your machine for you to see it. Here we have extrusion of endodontic material floating in the sinus. Might be concerned about that. This is extrusion of endodontic material very close to the mandibular canal and mental foramen. So definitely to be able to properly evaluate these, we might want a CBCT. Foreign bodies, absolutely. Help you to locate it better as well and become a real nice talking point with your patients. Anytime someone wants to do an apicoectomy, it's very smart to have a CBCT, again, just to be able to evaluate the surrounding anatomy and make sure that it's going to be a successful treatment. Perforations, yeah, we can see those. We can see this very, very minimal tooth structure left, and patient has persistent issues. So yeah, it's highly suggestive of a root perforation. Here again, we have a nice little perforation with surrounding bone loss. So not hard to be able to see that. Here's a root fracture case. This is the 2D. We can see we have a nice periapical hypodensity. It seems like it's centered at that root apex in our 2D. We do have a large post, but it doesn't look like it's involved that high up. But when we're looking at the CBCT, we have a J-shape hypodensity, goes right to the extension of that post. And so lets us know, yeah, we definitely have a root fracture. Here's some other fractures as well. So trying to determine what's going on with this particular tooth. This one ended up having a nice little fracture on it. There's another case with a root fracture, extensive amount of surrounding bone loss. So those are kind of the things, if we're concerned about a fracture, I want to see associated bone loss with that. That helps me to better appreciate that, yeah, this is a root fracture. It has the evidence of a root fracture. We can also see trauma. So this patient had a history of trauma. And I love it because 8 and 9 are totally different on this case. This is a really fun case. Here we have an intrusive luxation on 8. And of course, we have a fracture of that buccal cortical plate. And number 9 was an extrusive luxation. So this is kind of a fun one for being able to show what can happen. Definitely, this is going to require endodontic treatment. And of course, we can have our periapical cemento-osseous dysplasia, or fibro-osseous lesions that can look like apical lesions. It's why we should always vitality test these teeth. We can see root canal treatment's already been performed on this tooth. And unfortunately, it's just because of a fibro-osseous entity. The patient probably didn't need to have root canal treatment. So again, really good reason for CBCT. We can also have various pathologies. So here we have a large radicular cyst. Definitely can see exactly what's going on with loss of that buccal cortical plate. We can localize what tooth that is. This was a case, in fact, they weren't quite sure what was going on. Non-corticated lesion between teeth number 8 and 9. They thought maybe this was a nasopalatine duct cyst. That the CBCT showed that it was not. Maybe a possible fracture or an odontogenic cyst or tumor, but our canal was nicely intact. You can see that really well. Here's another one, corticated lesion over tooth number 8, and our periodontal ligament space is intact. So note that even on the 2D, you can see that, but so much easier on the 3D. So we can see that the mandibular canal is actually extending around it. It's being displaced. It's not associated with a tooth. And this ended up being an odontogenic keratocyst. So definitely want to get a biopsy on that. Internal root resorption, we can definitely see that. We can compare things one side to another. We can measure it. We can look at the fusiform enlargement. We can catch it early on when this patient's just starting to have some issues, slight widening of the apical periodontal ligament spaces. Here we have a granular appearance within that tooth. So you can definitely see that. And this is kind of an interesting case. I thought this was a little bit different. So we used to show this just in our incidental findings, but we've actually had several similar cases just in the last few weeks. So this is a 60-plus-year-old female. This came from the endodontist. They're concerned about this appearance on 2D. They think there's a periapical lesion. They're saying, do we need a root canal treat tooth number 7, or should we retreat tooth number 8? 9 was avulsed years ago. This is 10. So when we get into the CBCT, what do we have? We have an undiagnosed cleft palate that was discovered. We can clearly see the nice cleft, nice intact cortical borders. This right here is what is being projected across on that 2D image and giving us the appearance that maybe we might have a periapical lesion. So this was, it was an interesting case. We sent it back. We said undiagnosed cleft palate. And the endodontist actually called us and said, well, I talked to the patient and she said she doesn't have it. Well, she doesn't have what? Well, she doesn't have a cleft palate. And that's why I love imaging. I love CBCTs because it's the facts, ma'am. I mean, I've never seen somebody want to have root canal treatment, but evidently she would have rather that than have an undiagnosed cleft palate. So I thought that was kind of funny. But again, I added another one of these in here. This particular case, 40-something-year-old female, they've done root canal treatment on tooth number 10. They've done an apicoectomy. In fact, the history said multiple endosurgeries to save tooth number 10. They can't figure out what's going on with tooth number 10. They're thinking about extracting it and placing an implant. And this is what it looks like from our 2D image. Get into 3D, and we have a nice congenital defect, such as our undiagnosed partial cleft palate. And this poor patient has been through all of those surgeries. And if they'd had a CBCT, they would have known exactly what that was. It would have saved her a lot of time and money, and probably a lot of pain. Multiple idiopathic apical root resorption, definitely we can see that. We can see it really well with CBCT as well. All right, selection criteria for ortho, and I'm going to go through this pretty quickly because I don't want to take up more of your time, but I want you to be able to see some of these as well. They based it on the difficulty of the case. Is it mild, moderate, or is it severe? If it's mild malocclusion, CBCT may not be beneficial. You may not need it. If it's moderate, we've got class 3, we have an open bite, may be beneficial. And if it's severe, CBCT is definitely beneficial. So let's look at some of our cases here. These are all the reasons why you could use it with ortho. Again, it kind of gives you your justification from dental anomalies to any compromised dental alveolar boundary, any cleft, asymmetry. If you are a skeletal class 2 or class 3, might want to use CBCT. Vertical discrepancies like anterior open bite, deep open bite, transverse discrepancies like your cross bites, temporomandibular joint disorders definitely falls under here as well. Any of your craniofacial abnormalities like your cleidocranial dysplasia, hemifacial microsomia, airway assessments, any type of surgical procedures. If you're placing your little temporary anchorage devices, your little micro screws, or maxillary expanders. So it just kind of gives you the justification for using it. And here's some fun cases that kind of demonstrate it. Here we have concrescence or fusion of 2 teeth. They're fused by the cementum. And we've had several cases. I know when I was a general dentist in private practice, one of the partners was doing serial extractions on a 12-year-old female for orthodontic purposes. And he's struggling to get out the teeth. He's struggling to get out those first premolars. And all of a sudden 2 teeth popped out. So it was like 2 for the price of 1 day. What happened? There was concrescence, and it wasn't picked up from the 2D images. So if you're going to do serial extractions, you might want to have a CBCT. Supernumerary teeth, definitely a great reason for it. Many times our supernumeraries are swimming upstream. This little guy has erupted into the nasal cavity. So I guess to extract that, you're going to use the intranasal approach. Of course, if you have any type of long-standing supernumerary, you're going to have a resorptive process with that. That's very, very common to have these little resorptions with that. Lets us know that these are probably ankylosed. Various impactions, being able to unfold everything, figure out the path of alignment and that sort of thing. Definitely a nice reason to take a CBCT. Here again, we've got some external root resorption in our long-standing impacted teeth. Evaluating follicular spaces. These particular cases, especially in a young individual, maybe about 7 or 8, we'll get cases sent to us where they think that there is some type of a lesion. This is just our 3rd molar follicular space that's starting to develop. And sometimes we can have 4th molars as well. And so again, if we're trying to distinguish between a pathology, that's a good reason to go ahead and take a CBCT. Maybe we have asymmetry. So this is a right mandibular hypoplasia. Sometimes we're not quite sure, what's going on. Do we have hyperplasia on one side or versus hypoplasia on the other? We can go ahead and measure and evaluate these for proper asymmetry, and then try to determine, usually based on differentiations in our glenoid fossa region and how the bone is reacting to that particular condyle, we can tell whether we have hypoplasia or hyperplasia. This particular case, there is a cleft palate. So we can see that very nicely. We've got a right mandibular hyperplasia. So this one was a hyperplasia on this side, and temporomandibular joint disease as well. When we're talking about temporomandibular joint disorders, we use the research diagnostic criteria for TMD, which is a great tool. So if you haven't used it, definitely look this up. There's a lot of papers on it, and you can use the different decision trees that they have in their papers and questionnaires for use in your office as well. But it funnels like 11 different criteria down into 3 diagnoses of no osteoarthritic changes, indeterminate, or yes, osteoarthritic changes. And so we can see, for instance, this is nice normal cortical borders. This is normal. This is a bifid condyle, variation of normal, still nice intact cortical borders. And we start to see flattening. Now, flattening is indeterminate because this could be adaptive remodeling. You'll notice those cortical borders are thin and still intact. But then we start to see little erosions, like pitting in that cortical border, anterior osteophytes, medial osteophyte, and generalized sclerosis. We have generalized sclerosis, anterior osteophyte, thickening and sclerosis of the glenoid fossa region. We have a subcortical pseudocyst, multiple subcortical pseudocysts. These are just a breakdown of the bone in response to that inflammation. They are not epithelial lined. Another subchondral pseudocyst. We know we have osteoarthritic changes at that point. And here's some other examples of osteoarthritic changes. Again, we have our anterior osteophyte. Here one has broken off. It's floating in the synovial fluid. That's termed joint mice. If it's one, is it a joint mouse? I don't know. We have subchondral pseudocysts and that sort of thing as well. And of course, if there is any type of surgery, so an orthodontic surgery, or here we've actually had a complete condylar replacement for that particular case, definitely these are reasons to take a CBCT to have a better evaluation of what's going on with that patient. All your dental facial deformities, this is a hemifacial microsomia. That would be definitely a reason to go ahead and take our CBCT. We also have osteoma cutis with this. So this poor patient won the genetic lottery. We actually have agenesis of the condyle or condylar head on that particular side on the right side. So these are more advanced cases, and definitely a CBCT is going to be extremely helpful to you. This is cleidocranial dysplasia. Again, same thing, being able to figure out how to unravel the teeth. And we know they have multiple supernumerary teeth, and they're at increased risk for dentigerous cysts and that sort of things. Being able to evaluate the airway space and say, hey, there's a limited airway space. And certainly, if we're looking at a child, we're going to want to evaluate the entire airway space because we can see everything from deviated nasal septums to conchobulosa, hyperplasias of the turbinates, our mucocele, which we saw one earlier as well, or there might actually be tumor involvement. So definitely these are reasons that we'd want to have a CBCT to properly evaluate that patient that is complaining of airway issues. We can also have enlarged adenoids as well as palatine tonsils. And so this is a case you'd want to send to ENT. Go ahead and have the tonsils removed, and that's definitely going to help that patient immensely. And here we have enlarged lingual tonsils. So fun fact, if you have your adenoids and palatine tonsils removed, the lingual tonsils can start expanding in size to try to make up for that loss of tonsillar tissues. So, if the patient has already had their tonsils supposedly removed and they're continuing to have issues, go ahead and reimage them again and see if you have a compensatory enlargement of those lingual tonsils. And of course, we're going to have various pathologies within the airway space, various tumors and that sort of thing. And you'll want to send that on for additional imaging. Now, one of the things you want to take into account if you are treating patients for obstructive sleep apnea or any type of airway issue, we want to be able to evaluate the temporomandibular joints because there is an association between the two. The research demonstrates that there's about a 6-month difference, meaning we may not have placed that patient in a condylar conformative position when we placed her appliance. So we do want to be able to continue to monitor these patients, check the temporomandibular joints, make sure that you're not starting to see osteoarthritic changes and that sort of things with those patients. So way back when we used to place these devices, and I have to say, I didn't always monitor them, but now the research is letting us know we should probably monitor those 6 months to a year afterwards, just to make sure that we're not causing more harm. Because clinically, it can take up to 3 years to see a clinical difference, and by that time, there's a lot of damage to that to the mandibular condyles. So wrap up with our summary, and this kind of reviews the recommendations as far as the Syndentex project. This is the European Commission on Radiation Protection. All CBCT examinations must be justified, and I think we showed lots of reasons that they could easily be justified, but they want them to be justified on an individual basis to try to, make sure that the benefits are outweighing the risks for each patient. The CBCT examination should provide new information beyond what 2D imaging would show and aid in that patient's management. You need to have a record of that justification within your charts. That must be in the chart for each patient. And then routine CBCTs or screening with CBCT, they feel is an unacceptable practice where large volumes should probably not be routinely taken on every orthodontic patient, for example. And again, looking more at those advanced cases and that sort of thing. CBCT is not indicated as a method of caries detection. Very, very good. That's an excellent comment. We have a lot of beam hardening artifacts with CBCT, a lot of false positives. Now, the research does show that if the patient has no other metal in their mouth and they have deep caries, that CBCT will show the depth better than 2D imaging. But again, we have to be real careful with that. I would say we definitely haven't moved beyond those intraoral bite wings in a patient that has multiple caries. We still need to take those, maybe even along with the CBCT, to better evaluate the carious process. Saying it's not indicated as a routine method of imaging periodontal bone support. However, it can definitely be taken if there's infrabony defects. It's going to show that very well. If there's furcation involvement, if the patient has a lot of periodontal disease, definitely we can take a CBCT to better evaluate that. And we know CBCT does show periodontal disease very nicely. Assessment of soft tissue should be used or imaged with, I would say, MRI, ideally, and medical CT if necessary. But MRI is not using ionizing radiation, and so I tend to like that one better. CBCT may be indicated to evaluate bony invasion of the jaws by oral carcinoma. Definitely, if you think that you have any type of a, squamous cell carcinoma or large ulcerative lesion, we can take the CBCT and see if we have any type of bony involvement. And we're going to want to send them on for additional imaging as well. But this can help us with some of that initial early staging and that sort of thing. All right. And don't you just love our CBCT anatomy? As you're going through that CBCT, it just kind of smiles up at you so sweetly and lets you know, hey, have a happy day. So thank you very, very much for sticking with me. I know I was a little bit over, but I really appreciate your time. And I hope you have a great evening. And those that have questions, are there any questions?
Yes, there are. And I think we're all smiling. Some great little punches there. The synovial mouse or mice, that was wonderful. Yeah. And I think we were all taking a breath for you throughout the program. So great job as always. Yes, we do have some good questions. And we'll hang around about 5 minutes more just to make sure we get this all in, if that's fine with everybody. A question for you. Do you have a list of names of doctors or companies who read CBCT or recommendations?
Yeah, so you can go to the AOMR website, and that will have a list of places that you can go. I know for myself, we have an imaging center, or we have, I would say, a CBCT reading service called Dental Radiology Diagnostics. In fact, we actually have a button in some, like a plugin in some of the imaging CBC, or I guess with the CBCT companies. So you could actually just press the button, it would go directly to us. But yeah, I think if you go to the AOMR website, they're going to have a list of radiologists. You might be able to find somebody in your area, or maybe that's not so important to you. I know we read for anybody across the US as actually the world. So yeah.
Great. Okay. We've got a couple requests. If you had a template for the consent form or a recommendation.
Oh, that's a great question. Do I have a standardized
place they could find it?
You know, you probably can go again, look at the AMR website. I know that one of my classmates, his name is Vu Lee, he has something called Dental Friends, and I think he put one together. I helped, give the write-up part of it, and I think he was putting some of that together. But yeah, definitely something I should put on my website. So
Yeah.
thank you for the information.
We got a couple of those. How recent should your CBCT be prior to placement of the implant? Would you recommend?
That's a great question. Certainly anatomy is not going to change a lot, but I would think just because you're going to look at the surrounding dentition and that sort of thing, ideally we would like to have it within 6 months of placing that. I would say that's probably the ideal. And definitely if you're placing, sinus lift, bone graft, anything like that, you need to take a CBCT right before you're ready for that implant placement. Give it the longest amount of time to integrate properly, and then you want to be able to evaluate what you actually have. So,
do you recommend a CBCT right after placing the bone graft, or wait till it integrates or doesn't?
We see people doing that many times. After you place the implant, make sure that they try to put it in the right place. You may not need that. 2D imaging might be just fine for right immediately after, unless you feel that something has gone wrong. Then CBCT would definitely be helpful for that. Usually, you've taken it ahead of time. You go ahead and place the bone graft. If you take a 2D afterwards, just kind of make sure you've got it where you think you have it, and then let it sit for a little bit and then come back and take it again. But if anything has gone wrong during your procedure, if you do not feel confident about it, you can go ahead and retake that as well.
And some of the bone graft that got lost in the soft tissue or up into the sinus, do you do anything, or does that just resolve itself?
It depends on what it does. Sometimes the patient will swallow it. It's not a huge issue, but with some of the ones we showed here, they had an extensive amount of continued inflammation.
Okay.
In that case, you want to send them to ENT and have everything cleaned out and just start over again. It's just that the body is continually trying to wall that off, and it's caused a chronic inflammatory process.
Okay. What is the casting around the mandibular nerve? Question. I have found that automatic nerve mapping may not be accurate. Your thoughts?
So say that again. What is the
casting? What is the casting, CASTING, around the mandibular nerve? I have found that automatic nerve mapping may not be accurate. Your thoughts?
Okay. So I'm not entirely sure what the question is on this. They're using automatic nerve mapping software, which is probably looking at the various gray levels to be able to automatically map something. And in that case, that may not be exactly accurate, especially of a patient that has osteoporotic changes and that sort of thing. Because if you have an automatic segmentation tool of any kind, whether you're doing the airway or whether you're doing the mandibular canal, all it's looking for is a certain gray level to try to automatically include that in its segmentation. And so that can definitely be wildly off. In fact, all of my PhD was looking at segmentation and accuracy of segmentation. And we definitely found that the semi-automatic or even manual segmentation is going to be much more accurate than an automatic segmentation tool. There are various thresholds. So some of your software, you might think it's automatic, but it's actually semi-automatic, and you can actually play with the thresholds a little bit to adjust it to make it a little bit more accurate. But yeah, automatic segmentation is not going to be nearly as accurate as a semi-automatic threshold based or a manual segmentation tool. So
the automatic is more of a step towards the AI function, right? That everybody is hoping
Right,
for.
right. And so, and the difficulty with that comes into the fact that our CBCTs don't have true density like a medical CT would. So medical CT, that's going to be much, much more accurate than with our cone-beam CTs. And that's inherent with the difference, just the physics and the difference between a medical CT versus a cone-beam CT. A cone-beam CT, we don't have that highly collimated fan beam that we have with medicine. We have a lot of scatter. And because of that, we actually don't have the true density that we have with medical CT.
Okay.
With our CBCTs, we're just looking at gray values, and there's a randomized feature to that where that patient, sitting in that machine at different time points, those gray values will be different between that same patient sitting at two different time points. And it's going to make it much more difficult for an AI segmentation tool.
Maybe a good segue then here. I appreciate the issue with radiation, but I have never had to consent for x-rays when having medical procedures. Why are dentists so hounded about this?
That is a great comment. And I think probably it depends on where you had your imaging from, because I know I've had to consent to imaging before at a diagnostic center, that sort of thing. Probably, well, if you come into a hospital, it's all inherent in the consent forms that you sign for a hospital. So it may have been in there and you may not have realized that it is actually there. But you're right, dentists are really, really hounded with it. And why? Because our dose is so incredibly tiny. But the problem lies in the fact that there's a lot of us and there's a lot of imaging that we do. And so collectively as a whole, the dose to the population can be quite a bit. And so we always want to be careful with it. You're right that, medical doses are going to be way, way more than dental doses are going to be. Certainly our CBCTs are way less dose than a medical CT is going to be, but there's so many of us and we take so many collectively as a group that is the inherent issue.
Does it have anything to do with the placement and the organs or the area of the head?
So where you place it, where you take that image from, different anatomy will be within the field of view. And so there's been a lot of dosimetry studies, and I know you can go look up Dr. John Ludlow. He's done a lot of dosimetry studies, and actually he was my program director at UNC, and I'm lucky enough to work with him in private practice right now. So he is part of our private practice, but he did a lot of studies looking at dosimetry and location and that sort of thing. And definitely, if you were to take a CBCT in the anterior maxilla, there's really not a lot of anatomy. But if you were to take a mandibular one, well, now you're getting into maybe ionizing radiation to the thyroid and the salivary glands. And so definitely that makes a difference as far as the amount of dose.
Okay, and I lied. I'm going to stay on a little bit longer if you can, because great questions are coming.
Good.
And that's fine with you?
Absolutely.
We'll catch the first quarter a little bit late. Did you say it's not yet standard of care to have CBCT for all implant placement? How much more radiation a patient gets for 2 CBC, like pre and post procedure?
All right, so that's a couple of questions there.
Yeah.
So they have not used the terminology standard of care. They've kind of avoided it and left that up to the clinician, because especially the older, some of the older dentists or oral surgeons, they've maybe placed thousands and thousands of implants with 2D imaging, and they're really good at what they do. That's not to say that mistakes can't happen though. So I think that this is a really hot button topic, and that terminology makes some people really stand off on it. And we see that across the board, with all the dental professions, that there is, some of the guys that have been doing this, hey, I've been doing this my whole life and I don't need it. There's kind of a barrier there for acceptance of the new technology. And so I think as far as the American Academy of Oral and Maxillofacial Radiology has gone, they've been really careful with that type of terminology per se. If it becomes standard of care, it will be pressed from the legal arena. And that's what we are seeing. We're seeing this kind of stuff coming down from the legal arena, They're doing some of the same things we saw happen with medical CT. We're following that pathway with CBCT, because now, if the lawyer says, well, hey, they didn't have a come-in CT and it's readily available and they could have had it and it maybe would have saved the patient all this pain. That's what we're seeing happen. So this, if it becomes the actual terminology, it will be pushed from the legal arena. But, and again, the malpractice attorneys are the ones that are telling us that it's too expensive for them to defend that dentist if all they have is that 2D imaging. And there wasn't a CBCT taken for that pre-implant planning purposes. So ideally, it's smart to take a CBCT. Obviously, we recommend it. It's the recommendation given out by the AOMR to take a CBCT ahead of time and be able to more properly plan for that CBCT or for that implant placement, and to avoid any of the pertinent anatomy and that sort of thing. We know anatomy, again, it's quite variable. It does not follow the textbook. So yeah, now how much dose is that? We say one CBCT, for like comparing it with, say, a panoramic image, we can say an 8x8 centimeter field of view, which is maxilla and mandible, will be equal to about 5 to 6 panoramic images. Do you need one before and after? Well, definitely before. I would definitely take one before. After, you're going to have your implant in place. So if you take a CBCT after, you're going to have a lot of beam hardening artifacts, which can be confusing. And so our recommendation is actually take 2D after the fact, because that way you can see bone levels a little bit better. You don't have all those beam hardening artifacts. So ideally, take a CBCT, to do your treatment planning in preparation for placement, maybe send out for surgical guide, that sort of thing. And then after the fact, take a 2D image. Do we see people stopping midstream to take a CBCT to make sure that they're where they want to be? Yeah, we do. Is that ideal? Probably not, but if they feel they need it, again, it comes down to the clinician's judgment in their office at that time. So.
Okay, good. So if you need to take a CBCT pre-graft in order to determine if a graft is even needed, would you still take another one once the graft has osseointegrated?
Yes, the answer to that one is yes.
Okay, and then maybe 2D right after placement, you had mentioned. Okay. Would taking a CBCT every 3 to 5 years in lieu of a full mouth X-ray, and then taking 4 bite wings for caries detection purposes, be exposing a patient to much radiation?
That is a great question. Great question, because the doses with CBCTs are low. We can say that a CBCT is actually less dose than some of those, full mouth series, the film-based full mouth series. In fact, you could have taken 3 CBCTs for what those original film-based full mouth series were. So certainly it's less dose than that. It's just a little bit more than a direct digital. So a direct digital will be, maybe about 4 pans, where if we're looking at a CBCT, we're looking at 5 to 6 pans. It's a very negligible dose addition, and you're going to get a lot more information from that. So, I have to show you what the 3D selection criteria says, what is being printed, what is out there. But also take into account that now with, what the doses are with CBCT now, and for bite wings, it's very similar to what we had before, and we have a lot more information. We're seeing many people move towards a CBCT and 4 bite wings as their full mouth series. And I don't think that's bad.
What about I think it was during the pandemic, the CDC came out, or ADA, not to take intraoral, and now some systems propose extraoral bite wings. What's your feeling on those?
So that's a great question as well. So definitely, during the pandemic, I think it was even more reason to get a CBCT personally, and those extraoral bite wings. Well, the problem with some of these extraoral bite wings is we have to remember they're still using that panoramic geometry. And when we're looking at the resolution in a pan, we're talking about like 2 line pairs per millimeter. So they're very, very low resolution. A lot of the research we did shows that the lesion has to be pretty large for you to be able to pick it up in those extraoral bite wings. But that being said, it is a tool in your toolbox to be used, especially, during COVID. Maybe you don't want to have, don't want to be in the mouth. If the patient has a gag reflex or anything like that, it's just like everything else. It's a tool in your toolbox, but we need to know that there are some cons to it, that it is a low resolution image, that it's not going to be the same quality of an intraoral bite wing. So if we're looking for small caries, just know you're not going to see that. But if you're looking for large caries, you can go ahead and see that with your extraoral bite wings. So.
Great. One last question, but maybe we've got it answered. Let me just check if I understand it. Do you always take a CBCT after grafting? No, you're recommending 2D immediately after grafting, unless there was any complication in the case in that case. So that answers that question. So wonderful to learn from you always, Dr. Kohltfarber. Thank you so much for taking the time. We got bonus time tonight with you. So thank you for the great presentation as always. And a couple jokes. It was fun to laugh with you. I just want to let everybody and thank everybody for sticking with us. Even we had high numbers sticking with us this long. So if you're interested in attending future Henry Schein webinars, please visit henryscheindental.com/webinars for our upcoming schedule. And if you have any ideas for future webinars, you can email us at webinars@henryschein.com. And please remember, everybody watching, and there was so much information provided, you may want to repeat this so you catch it all. You'll get an email with the recording linked in the next week. Thank you all for joining us. Go Bucks, because Henry Schein has a Wisconsin facility for us, so we hope the Bucks win it in 6. And we look forward to seeing you all on future webinars. Thank you, Dr. Kohltfarber. Wonderful to see you again, and thanks for everybody's attention. Have a great night.